Good afternoon, everyone, and thank you for attending today. My honor and pleasure to introduce to you Ms. Sugar, who started her career in vascular testing in Chapel Hill, North Carolina in 1978. She spent most of her career in an office-based laboratory. In 2008, she formed a private company which provides vascular practice management and compliance consulting services. It has represented SVU on the IAC Vascular Testing Board of Directors from 1995 to 2011, President-elect, and Secretary. And in 2007, she was elected Chairman of the IAC for a 2-year term. She also held various positions on the SVU board, such as publication staff, many committee roles, and served as Secretary, Vice President, and President, and continues to work tirelessly for the advancement of our profession. Having said that, it is my pleasure to turn the webinar over to Rita.
Well, thank you. Let's the slide here. I have no disclosures except that I am, as Marge said, President and owner of Shugart Consulting. Well, probably of us are familiar with the IRS tax forms that we have to fill out every year, and lines for the income and deductions seem simple enough. We all know that a lot of work is required prior to completing our tax return. And the tax code is thousands of pages long, difficult to understand, and yet the consequences of submitting inaccurate information, even inadvertently, affect income and can be unpleasant. Situation is also similar to that of the Medicare Claim Form 1500. While around a diagnosis code and a procedure code or two seems easy enough, it's not that simple. Medicare has hundreds of thousands of pages of regulations. How can we be expected to perform exams, do all the associated paperwork, maybe supervise others, and keep up with all you need to know these days? And yet, like taxes, if you don't do it properly, it can affect the income of your facility, and the penalties can be severe. Today, we're going to discuss some of the key items that you need to know about, so that you're doing things properly in order to get appropriate reimbursement for the tests you're performing, and to clear regulatory compliance problems. Obviously, in the time we have today, we'll not be able to address all of these issues in depth. We're hoping to give you a broad overview of the items that are most important, LCDs, orders, coding, reports, and we'll also discuss some of the risky practices or behaviors that may put your facility at risk. I'll try to go through a few case studies, if time permits, to illustrate how all of these items may or may not come together. Well, we're going to talk so much about Medicare policies. Several reasons for that. First, traditional vascular lab that does a large variety of studies will have a large percentage of Medicare-age patients. And many private insurance companies follow Medicare policies. Medicare posts their policies. They may be buried among hundreds of thousands of pages of documents and hard to understand and even harder to follow, but at least they're published. Many insurance companies don't publish their policies until payment is denied, so it's harder to understand their policies. Let's start LCDs, local coverage determinations. Local coverage determinations. Perhaps nothing is more important for understanding and getting appropriate reimbursement for vascular lab studies than knowing and understanding your LCD. Many people who are not already familiar with LCDs are truly shocked at just how restrictive these policies are. These are policies put out by Medicare in each state, although not every state has one, that typically include infant and regulatory information about all of the things that you see listed here. And we'll go over a few of these items. This is an example of the accreditation and certification language that's found in the LCD for Jurisdiction 11, which covers North Carolina, South Carolina, Virginia, and West Virginia. Those are the states in which I work most often. I live in North Carolina. And while this LCD requires certification or accreditation, more LCDs in other states are beginning to require both. So see that this LCD requires that one or the other be in place. You have to have credentialed persons perform tests, or the lab has to be accredited. And then it gives the examples of the certifications and accreditations that they will accept. They also want to list some more restrictions. For instance, at the very bottom, laboratory accreditation should be specific to the testing being performed. That's to prevent a lab from becoming accredited only in one testing section and then performing all types of testing in their minds. Now, if you look at these LCDs, if you're not already familiar with them, you'll find that they have some narrative portions and then some table functions. The patients in Carotid Duplex, for example, testing, this comes from this list that you see in front of you, comes from the narrative graphs in the J11 LCD that we're using as an example. And you can see that when you first read that, it doesn't look so bad. It looks like it's pretty much the things that we see a lot of patients for that need a Carotid Duplex exam. And the list of things that Medicare considers to meet medical necessity. Medical necessity is key to the Medicare system because they will pay for only items that they consider medically necessary. Notice I say that they consider medically necessary. What a physician or vascular lab or anyone else considers medically necessary, just what Medicare does. And change depending on the policy and depending on the LCD. The LCDs vary from state to state. But at glance, this doesn't look so bad. Typical things we see patients for. So in addition to giving you that narrative portion that specifies certain items, what really is important is a list of ICD-9 or diagnosis codes that they give you, because this is the item that actually goes on their claim or any other insurance claim. It specifies the reason that you did an exam. This is how they give you a table showing you specifically what diagnosis codes you can use that will meet medical necessity requirements in your minds. Well, as I said, first list, the narrative list, didn't look so bad. But to the actual list of items you can pick from, LCD for Jurisdiction 11 was first published, there were some significant problems. These codes that you see here for the first items, Carotid Duplex, this is just an example of some of the ones that are left off. And see, if you look at the bottom item under Carotid Duplex, 784.2, swell mass or lump in the head and neck, something we use sometimes when we're doing a diagnosis code for what may turn out to be a carotid body tumor. That code, though they said, if we go back in a list of them, if you look at number 3, said that was okay in the narrative, but when she put in the list of codes from which to choose, it was left out. Now, we actually ended up contacting the Medicare contractor and asked to have these codes inserted into the list of items that were acceptable, and they agreed to do that, but that is not always the case that they will add additional items. So you can see that these lists will include items that we sometimes see patients for. For instance, a section of the carotid artery was initially left out. Also under TCD, you can see that they initially did not include sickle cell trait or sickle cell disease unspecified in their first list that was put out by this care contractor. So each state is different. Each state has some items that are we would expect to see, and almost every state has some that we would expect to see and not included. Problems with these local coverage determinations, really too many for us to go over here. I said they're local, they're used in every state, but there are a majority of states that have these, and we'll go over the list of states in just a moment. They're applied to more laboratory settings than ever before. In the past, hospital labs really did not have these LCDs applied to them, but now, because of some Medicare contractor reform, they are having them applied to them more often than ever before, and the hospital labs are particularly unaware of that. So if you're listening and you're in a hospital lab, pay attention, because this may apply to you in the state in which you practice when it did not apply to you in the past. Now, all the states that do have LCDs, or local coverage determinations, do have certification and or accreditation requirements. And sometimes these requirements have a significant impact on who may take call for the labs. If you have non-credentialed people that need to take call and your lab is not accredited, that could be a compliance issue. These policies get made with with little representation on the committees that make up these policies. So that's one reason among many that these policies don't make a lot of sense. They're incomplete, they're contradictory, they're inaccurate, they just don't make sense, and they do exhibit a real understanding of what we really do in practice every day. And some of the states have policies or LCDs that are much worse than the one I just showed you. So they can be a real problem because they control so much of what we do and have so many issues that create problems for us in our day-to-day lives. Now, this is another example from that Jurisdiction 11 policy that will show you just how much they do control what we do. This is how often they suggest that carotid duplex be performed on patients that have known carotid artery occlusive disease. And then they say if you an 81 to 99% stenosis and don't have surgery, you don't need any more surveillance after that. But people would disagree with that. This is the guidelines for lower extremity arterial bypass graft surveillance. Gives you some guidelines for that. And then after stent or PTA, after 1 year, they don't recommend that you do it unless the patient has new or recurrent symptoms. States actually have vascular LCDs, or local coverage determinations. If you work in an outpatient facility or an independent diagnostic testing facility, you file your claims under Part B. So all states, except ones you see on the left-hand side of your screen, have LCDs that apply to them. If you're in a hospital, inpatient facility, or if you are in an outpatient clinic owned by a hospital, an imaging center of a hospital, doctor's office that's owned by a hospital, an inpatient, a hospital-owned imaging center, you file under Part A. And there are 30 states that have them, and they're listed here, 30 states and jurisdictions, because D.C., Puerto Rico, and the Virgin Islands are also listed there. I'm not sure if you're Part A or Part B because you're in some strange clinic or outpatient setting, but you have some relationship with the hospital, you would ask somebody in your facility which one of these apply. So this list, I will warn you, changes very, very frequently. So you, I did this just a couple of weeks ago, but when people call me and ask me if they have an LCD that applies to them, I never answer unless I check it that day because they can change that frequently. So what do you need to do to find out more about LCDs because they control so much of what you do on a day-to-day basis? Well, first thing you've got to do is find out if your lab is Part A or Part B. Then you're going to go to this website that I'll view on the next slide. We will also show that again at the end of the presentation to see if you have an LCD for your state and your Part A or Part B facility. You do want to check often for the updates and the changes because of the situation now with a lot of contractor changes for Medicare. And just because you have one now, you may change. And even if you don't have one now, you may have one in the future. And even if you don't have one now, there's still going to be a lot of regulations that are still going to apply to you. This is a website. I know you won't have time to write it down right now. The presentation will be posted on the IAC website as well. So if you don't have time to get it now or later today at the end of the presentation, you'll be able to get it at some point. And we will give you contact information for me as well if you have trouble accessing it or figuring out if an LCD applies for it. Applies to your facility. I can't stress enough how important it is for you to have an LCD and follow the regulations that are included in it. Well, on to orders. Orders are important because you must have an order for the test you do. If the order is incorrect, expected to get a corrected order. There are circumstances in which an exam may proceed before the corrected order is obtained. When the order is clearly wrong, even to a lay person, for instance, if the eyes were ordered on someone whose leg has been amputated, or if the exam would pose a threat of harm to the patient. But circumstances have to be documented, and they can't be routinely used to circumvent getting orders. You have to maintain copies of the orders in case of an audit. That a lot of physicians don't know, the vascular lab itself doesn't have to deal with this personally, but the referring physician, when ordering the test, must document his intent to order the exam and the reason he's ordering it in his or her office notes. That be asked for in the case of an audit. Now, what is the definition of the treating physician or practitioner? I usually include this definition because sometimes people misunderstand when they hear that they have to have an order from the treating physician or practitioner. That does include physicians who furnish a consultation. So a consulting physician may order an exam. The last item on the list, a physician uses the results of the diagnostic test in the management of the specific medical problem, has caused some compliance problems, and we'll talk about that when we get to the case studies. On to Cpt coding. There are two types of codings that vascular labs deal with, diagnosis coding and Cpt or procedure coding. Cpt codes are those 5-digit numerical codes that explain in shorthand just the exam we're performing. The non-invasive vascular diagnostic studies section of the Cpt book that you see shown here contains only 26 different test types. I'm going to go over just a couple of things that have changed in recent years. This first one is something old. This took effect January 1st of 2011. There were changes in the wording of 3 arterial physiologic codes. The 93922, which we typically call ABIs, these are physiologic tests only. The 93923, which you may, for shorthand, refer to as the segmentals study, or PRs, something like that, and the 93924, which we typically call the exercise exam. Now, real specific instructions can be found about these 3 studies in the Cpt code book. So not aware that these changes took effect over a year and a half ago, then you need to be looking at a Cpt book to make sure you're doing them properly. One I continue to see being misused almost 2 years later is the lower extremity exercise code, the 93924, one of those 3 I just mentioned. The definition of this applies to the lower extremities only. It can be used for thoracic outlet syndrome, can't be used for toe-ups, can't be used for walking in the hall. The components that you see on the screen here must be included if you're going to bill for this code. So it has to be a motorized treadmill. It has to be bilateral. I actually had a patient with an amputation and a prosthesis who wanted to get on the treadmill, which was motorized, but that wouldn't work because you can't really do the stop AIs. It would work, but you charge for this code. So I didn't really feel like it was that safe for that person to be on the motorized treadmill. But again, the biggest problem I see is people using this more for thoracic outlet or positional maneuvers or for toe-ups or walking in the hall or reactive hyperemia. So realize that this has changed. In 2012, January 1st, there were 2 code changes. There was one deletion, that cerebrovascular physiologic studies that people sometimes use for the old OPGs or the periorbital exam or spectral analysis. There was one addition, the 93998, an unlisted non-invasive vascular diagnostic study. That I would not recommend that you use that study or that CPT code. That's why the caution sign there. There are no RVUs or fees associated with that particular study. So submit a claim using that code. The Medicare contractor or any other insurance company is going to ask you to submit a copy report that shows what you've done. And they will decide how they're going to pay for it and how much they're going to pay for it. And trust me, they're going to try to pay you as little as possible. So I only use that if there's absolutely nothing else in the world that you feel is appropriate from the list of the studies available to us already. This is not something anybody asked to. This is a code that's available in other parts of the CPT book, and I think they just added it for consistency. So I recommend that you use it. So here are excerpts from the CPT book itself. One of the things I find in visiting labs throughout the country is that while labs may have a list of the vascular CPT codes, that list may have been supplied to them by their employer, and many people have never even seen a CPT book. And that can be unfortunate in some cases because sometimes the important information and instructions that are in the narrative paragraphs that are in the CPT book are not included in the list that labs are given by their employer. So this is information that labs really need to have sometimes and really can affect the way they perform exams. Affect compliance, it can affect reimbursement. The direct quotes out of the CPT book, this is in this 2012 book, but been in there for years and years and years, exactly stated as you see here. The one I see most often misunderstood or misused is the prohibition against, is number 2, the prohibition against performing physiologic studies using equipment separate and distinct from the Duplex scanner. I see a lot of labs that use the Duplex scanner to perform their APIs. That is not appropriate according to the CPT guidelines. Physiologic studies, if you're charging for 93922 or 93923, are expected to be performed using equipment separate and distinct from the Duplex scanner. It doesn't say a probe separate from the Duplex probe or the P probe. It says equipment separate, and it's intended to use physiologic equipment. Photoplethysmography is not a covered service. We do photoplethysmography often in vascular labs for digital studies, cold sensitivity studies, but we can't charge by itself. We usually charge for it as just something that's included with some other type of test, a lower extremity arterial or upper extremity arterial exam, but not by itself alone. Here's some other excerpts that tell you must include for a complete transcranial study or a limited transcranial study. And here's a prohibition on the bottom of the page about not charging carotid IMT studies as limited cerebrovascular exam. They have their own Category 3 code. There is not reimbursement for it, but they do their own code. Rules for CPT coding. You want to know the definition of the CPT code that you're assigning to the study. Must include all the components of the procedure that are in that CPT code. If you can include all those components or the exam you're performing doesn't meet that definition, then you've got to choose another code, or you can sometimes use a modifier that says you're doing something a little differently. Because everything we do the documentation, which is our report, must fully support what we've put on the claim. Examples of what I mean by those 3 things. If you build that exercise exam that we've already talked about for a thoracic outlet exam or a lower exercise exam with toe-ups or walking in the hallway, you would not have included all those components that are required because we know you have to have a motorized treadmill. We know that it's only for extremity. 93990, duplex access station, if you only perform the exam of the access site, that would not meet the definition of the CPT code because that code requires that you look at the arterial inflow, the access site, and the venous outflow as well. So you would have left off some of those components and it would not be meeting the definition. If you 93922, that lower extremity arterial physiologic limited, what we for shorthand called an AEI, on someone who only had one ankle, you're instructed to include the modifier -52, which indicates a reduced service or less than service. The 93882, the Carotid Duplex Limited, is not for IMT, as we've already said. IMT has its own separate G code. So documentation must fully support what you put as the CT code on the claim. If a report read only antegrade flow in vertebral arteries and you had billed for an upper extremity arterial duplex, that would not be sufficient documentation because the upper extremity arterial duplex does, of course, require some arterial segments be examined. And if you billed the TCD complete and only mentioned the intracranial vessels, the intracranial ICA vessels, that would not be complete documentation because you're required to examine other arteries as well. So let's talk about diagnosis coding. Diagnosis coding, or ICD-9s, are how we tell insurance companies, Medicare or private insurance companies, the reason we're doing an exam, the indication. So what you know is the same thing that we always say on, just like we said for the CPT codes, you've got to know the definition of your ICD-9 code, the patient's clinical condition history, or the test results, once you've performed the exam, must meet that definition, and it's always the report. So support whatever you put on the claim. So the diagnosis or the reasons for the service being provided. Some have a diagnosis that does not meet the definitions of necessity in an LCD. For instance, I do a carotid for headache, which would not be allowed in any of the LCDs I've ever seen. But if you find that they have carotid artery disease or carotid artery stenosis on the exam, you can change, then that code can be used, carotid artery stenosis, which is allowed by the LCD and is reimbursable. So that is the second item, the second bullet point. You can code a confirmed or definitive diagnosis that's documented by the diagnostic test. What you don't want to do is use the initial referral indication if it's inaccurate. And people want to argue with me about this, and in some facilities, in fact, vascular labs are required to put down whatever the initial reason for the exam is that they were given. But trust me, somebody in that facility, if that's the case with you, somebody is changing it later. Because if not, and the referral indication is wrong, then that is fraud. And we're going to talk about fraud and things like that in just a minute. Now, for inpatients, you can use things like rule out suspected, probable, or questionable, like rule out DVT, suspected TIA, suspected stroke. But on patients, you cannot. And if you look at LCD and you see a list of items from which you can choose that meet medical necessity, you will never see those words. So it will not be allowed for outpatients, any LCD or in any setting. But hospitals are different in this respect, so that is a difference between the two. The do for ICD-9 or reasons for tests is to someone to give you symptoms, conditions, but symptoms unless they are absolutely certain this one has a condition it's symptoms. I mean by know the definition of the ICD-9 code. Well, a lot of people want to put down claudication and think that they know what that means. That's the 440.21. They think that anytime somebody's leg hurts when they walk, that's claudication. But the actual code, if you look up the definition, says atherosclerosis with claudication. It doesn't mean anytime your leg hurts when you walk for any reason, joint pain, gout, muscle strain, or anything else. It means atherosclerosis with claudication. And same thing with rest pain. 440.22 is not the same as pain at rest. It is atherosclerosis with rest pain. So you want to know what your definition is before you assign a code if you're in a facility where you're responsible for that. Here's an example of the patient's clinical condition, history, or test result must meet the definition. If a patient has a family history but no personal history of a AAA, you want to put down that they have 41.4 on your but that is going to have the report say they have no evidence of a AAA because you've just said that they do by using that code. Here's an example of where the report may not support what you've put on the claim. If you use 440.21, atherosclerosis with intermittent claudication, but the report only describes symptoms of burning and stinging in the toes and feet, well, that is not claudication, and not put anything on the report in the indications or history section to support claudication. If you put a 4.9, but the report shows only headache, then that would not be necessarily considered TIA. It would look to auditors as in both of these cases, you were putting down a code that is reimbursable, but an indication that is not reimbursable, and that you were trying to get payment when payment would not normally be due. All right, talk about reports. Now, the medical necessity is established on a report is through the indication section and the impression sections. There are other parts of the report that are very important, but this is the way that Medicare and insurance companies look for medical necessity. So indications, they don't want you to use that numerical justice code. That's going to go on the claim, but that narrative, words, paragraphs, doesn't have to be a paragraph, but they want some information in words, not a number. They want it specific to that patient for that exam on that day. They don't want you to recopy day after day, time after time, the previous history. It is totally relevant, and they want it to be sure that it is exactly the same. Our impressions, you want to relate your impressions to the diagnostic criteria for that particular exam. That's where accreditation becomes helpful because you know what your diagnostic criteria are. It's easy to make impression relate to that. If you do want to make them complete, easy to read and understand, that's obvious to everyone. You want to include some space for all the required components of a CPT code. You don't use some lab-specific that you've made up, because if someone is reading that report from an insurance company, they aren't necessarily going to know what your pre-CABG study means, or your Elvis study, or your pre-op exam. They're going to be looking at that in terms of a CPT code or a procedure code. They want that exam to have some relevance to the CPT code, or they don't understand if you've even met the requirements of the CPT code. I recommend, and this is my recommendation, it's not a regulation, but my recommendation is that you don't put two reports on the same report, two types of studies on the same report form. The reason is that if you have to submit a report form for an appeal or because of an audit for some reason, you want to show that you have done two separate bodies of work. When anybody sees the two reports or more combined on one report form, it tends to minimize the amount of work that you have done in their eyes. And I think that we all know that doing two studies is quite a bit of work. The final report should stand alone. That means you've got to have all the documentation in that final report. So if waveforms are required, the final report that's available in a medical record has to include that. The waveforms or other things cannot be kept separate. They have to be available as part of the permanent medical record. Now, some examples of just some reports that actually been scanned in, and that's why they're not such great studies, and we're going to go through these really quickly because we're getting short on time. And these are not the world's worst reports, but all of them illustrate something that's not the best. And if you see something that relates to something doing in your reports, it might just give you a reason to sort of rethink how you're doing things. But this particular study is a carotid ultrasound. There's no indications on it, and these are all reports from Vascular Labs. There's no velocities in here at all, and no documentation that this is complete exam was performed, because the only thing they ever mention is the ICAs. All of these reports, with a couple of exceptions that I'll mention as we go along, could create some compliance problems if the lab were audited. The report isn't terrible. They do have the indication, and it's pretty good because it's got all the velocity. This is actually a decent report. Nothing really wrong with that one. This one has no indication on it. There's a place for all the data, the different arteries, but there's velocity. So it's not really good for follow-up for if it's done in that particular facility or certainly in any other facility. This one is okay, but if you just look at it and glance at it without even trying to read much, you can see that the diagnostic criteria is the most prominent on the page right here. And really no reason it should be. No reason that couldn't be smaller. This report, even try to read this. This one, nothing wrong with the data here. It's just that it's too busy. Where physicians don't want to read all of this. It's hard to read. They don't understand why there's so much there. It's just confusing to them. No reason that all that has to be on there probably. This is an upper extremity arterial PVR study, and this one one of those situations where the report does not stand alone, because this is what was in the medical record. There are no waveforms, and it says it is an upper extremity PVR. It mentions the waveforms, and it mentions segmental Doppler pressures, but nowhere are they included with this report. This single page is the whole report. So that does not meet the Cpt code definition, which does require the documented waveforms. And it also mentions an imaging study. It says it was not performed, but I'm not entirely sure why an imaging study even put on an upper extremity arterial PVR study report form. This is a TCD, there's no indication, no velocities, and no indication in this case of how the velocities were measured. Is it time average, mean maximum, or just what? This supposedly a lower extremity arterial duplex, as you can see here, but what it actually is ABIs, and that's all it is ABIs. But there's no raw data. There's no actual numbers on here. Again, there's no waveforms. This was the complete report. This is a lower extremity venous, but it doesn't even indicate on this case where which veins were examined, and in fact, it doesn't even indicate if this is the superficial system. So that would be adequate. And this saphenous vein mapping, it's got the diameters and it's got some impression, but it never has in place for the indication. There's not even a field for that. And this is just one of many report systems. There are a bunch of different good reports. There are as ways to do good reports as there are ways to do reports. And this one is a pretty good example of how you can do some good reports. We'll talk quickly about some risky practices. Some risky coding and billing practices include Medicare's #1 source of fraud, and that is incorrect reporting of diagnoses or the procedures to get maximum payments. That is #1 fraud problem with Medicare. Now, tests on the same date of service is not prohibited, but a lot of times that can be a source of problems for Medicare, and they look at that depending on how many you do. 2, and some, depending on the combination, is is not necessarily a problem, but it can be an issue if you do 5 or more. Routinely use modifiers to bypass some edits that they have in place. If you always bill complete exams and never bill a limited exam, that may just raise a question in their mind about why that would be the case. It's not that it's necessarily wrong, but might tend to look at that. If you frequently bill a structural exam and a vascular code from the same body parts together, for instance, a renal vascular duplex and a kidney ultrasound always together, they might look at that. Some documentation practices that might cause eyebrows to be raised. If you don't document your medical necessity well, and we've already talked about that, having ambiguous or lab-specific names so that it's unclear to them if what you're doing is matching what you billed for, and if your documentation doesn't support either the procedure or the diagnosis code. So here are ways you can get audited. And a friend of mine who used to work for Medicare and is now a consultant for evaluation and management consulting, now it's not a matter of if you're going to get audited, it's just a matter of when. And probably the people that come to audit aren't going to be as good looking as George Clooney. But Medicare has a lot of ways they did not have in the past to evaluate you, a lot more robust systems. So sometimes they just do stuff randomly. One of the biggest Medicare frauds in history, $375 million, was found through random sampling. They file you. If you have a change in billing patterns, for instance, if you have a mix of complete and limited exams of a certain type, and then all of a sudden you only start billing complete exams, they look at that and find that through their electronic systems, and that might create an audit trigger. There's a lot of differences in the states you live in: New York, New Jersey, Florida, Texas, California. Those areas where they really have a lot of fraud and abuse, and they look at those states even more with even more scrutiny. Practice settings: independent diagnostic testing facilities have a lot of regulations. Regular labs and hospitals don't have, and a lot more scrutiny. We talked about some other things. If you always code the same reason for an exam, and then there's the RAC, the recovery audit contractors that people have heard about, the bounty hunters, and then there's the whistleblower lawsuits that people have heard about in the past. These are audit items that may be requested in an audit: the signed orders from the referring doctor that we've already mentioned, the referring doctor's intent to order, and who's performing the studies. Here's a few things that they're doing new in Medicare prevention. They have all kinds of new programs. They have these hiring private investigators to conduct audits of independent diagnostic testing facilities. They have this Medicare Patrol, this heat strike task force, pay senior citizens up to $1,000 to report Medicare fraud, so secret shoppers. And they have these things called comparative billing reports, where they send you something telling you how you compare to similar labs. I have a client who got one of these, and he was told that he was billing 75% more than similar physicians of his specialty. He was doing an average of 2 carotid studies a week in his accredited vascular lab. I didn't think that was really an excessive number. Let's talk about just a couple of case studies in the 2 minutes we have left. This was an cardiology-based office lab that was doing surveillance of endarterectomy patients, post-op patients. The exam was performed by the technologist, but the patient was not seeing the doctors because they'd been released by the doctors from the post-op period. Everything was okay on the exam that they were having done. The tech write down the time for the next appointment, 6 months or 1 year later, and then the appointment was made, and they just still didn't see the doctor. The issue that brought up were that there was no orders for those exams. The tech was just writing down the next appointment, and the tech wasn't fulfilling his responsibility as a treating physician. Remember, we talked about that. He wasn't using the results of the test in the management of the problem. So it was a problem. And then could have been charged and wasn't, but could have possibly been charged with medical negligence. And you see the definition of medical negligence there. So the outcome was that no appointments are made. Check out, the physician actually, when he reads the study, completes an order form for the next appointment himself, and he sends a follow-up letter to the patient regarding the results of the exam. So there is some follow-up management of the patient based on that. And he has to actually see the patient, or the PA in the office sees the patient at least every 2 years. I think we're going to stop here and the remaining case studies, but you will see them when you go to the site after the presentation is posted. And I'm going to turn the presentation back over to Linda and let her ask a few questions, the remaining 10 minutes that we have.
Thank you. Of course, we have lots of questions coming through. If you would like to post a question, please enter it into the Q&A panel. Enter your questions into the Q&A panel on the right-hand side of your screen. And I try to read off as many as I can to have Rita for those online. And there's some that are some duplicates and some of the commonly asked ones that Rita usually gets. Different people have asked in a couple different ways, can they do 2 studies on the same day, Rita?
Yes, that's a really common question I get, because a lot of people have been told in the past, and it was a problem in the past, and they were told not to do 2 studies on the same day. The correct answer is it really just depends. It depends on which exams you're talking about. There's something called the CCI, or Correct Coding Initiative List. It will tell you which procedures, which codes, procedures you can and can't do together. Actually, it tells you which ones you can't build together. And it depends on the reason for the exam. You've got to have medical necessity for both exams. We'll just pretend we're talking about 2, but this would all apply whether you're doing 2, 3, 4, whatever number. Both to be medically necessary, so they separately have to meet the medical necessity rules. They both have to meet the LCD requirements. They both meet all the things we've already talked about, the definition of the billed CPT code. And they can be what's called bundled codes. So, for instance, a Carotid Duplex complete study can be billed at the same time as a Carotid Duplex limited study. So that, because limited is considered part of the complete study. Now, that's not the same thing for every complete and limited, but there are several that are like that. So you just have to figure that out. There are a lot of studies that we do that we can build together at the same time. For instance, what I typically call AIs, we all know that's not the right term, but AIs 93922, the lower extremity arterial physiologic exam limited, can be, it often is billed with a lower extremity arterial duplex exam, for instance, if you're doing a bypass graft or imaging of the native arteries. That's pretty common.
So Rita, specifically, are there any issues with doing an arterial and venous duplex on the same day?
No, and if you do that, I would, if possible, I would try, if there are separate reasons or distinct reasons for doing them, I would use a different diagnosis code for each. It's not required, but if you have a reason, I'd use a different reason. If you're trying to build 2 of the same code, for instance, an upper extremity venous and a lower extremity venous, they almost always will deny that. You can use a modifier, a -59 modifier, to show that they were 2 separate and distinct services. They should pay for that, but a lot of times they won't without you appealing it, meaning you have to send in a report showing that you did do something separate. Again, if you have the reasons for doing them, one, the lower extremity was for, was for swelling or history of DVT, and the upper one was for pre-op, access site or something. So if you can use separate reasons for doing it, separate diagnosis codes, that's always better. And sometimes just be prepared to appeal it or ask for reconsideration.
Okay, we have 2 folks, at least 2 folks that are asking. Lisa and Lynn, I'm seeing, that ask about the terminology rule out was used. One particular was asking if rule out used in hospital setting, and another was saying they would not get paid if they used rule out, even if it was an inpatient. And
well, actually, rule is allowed in a hospital, but when I have hospital labs, I don't recommend that the hospital vascular labs use it because it creates problems. It'd be better for the doctors to put down what the symptoms are that they want, that causing them to want to rule out. So instead of rule out DVT, maybe they could tell you that there's swelling or pain or whatever. Because if you have rule out DVT, the physician that reads it cannot get, because he's going to bill from Part B. He's not going to get paid at all for reading that study, and eventually they'll be kind of annoyed about that if you have a whole lot of rule outs. That's not the primary issue, but that is one issue. Second of all, it's really just better to know what you're dealing with. Why are you doing that? What is really going on with that patient? Because if you know, for instance, the patient, it's a clinical issue as well. If you know that patient has pain or swelling, and that's why you're doing it, maybe you're looking for something else. Maybe you're finding a Baker's cyst or something like that. But if it's a rule-out DVT, maybe it's a rule-out DVT because the patient has shortness of breath. And it just makes a difference in the studies you're doing sometimes. So really, it is permitted in hospital, but I don't really recommend it. I think it's always better to get a symptom.
Thomas was asking specifically about the frequency of carotid duplex exams. He asked if the frequency is that you showed on slide 15 is universal.
It may not be. It's not an uncommon frequency, but you always have to check your particular LCD, because the LCD varies by the LCD in your state, if you even have one. LCD is what I'm saying. But some places will allow it annually after endarterectomy, and some will only allow it at 1 year. But a lot of differences. And realize, too, that you may have a patient with an endarterectomy on one side and some disease on the other side, and those two sides may have a different frequency of follow-up in your LCD. I say follow it with the most frequent. So the endarterectomy side has been 4 years ago, so the side is only annually by the LCD, but the patient has 79% on the unoperated side and get studies every 6 months. Follow them every 6 months. Does that make sense?
So
you've got to follow your own LCD for your state.
Right. There's a lot of questions coming through. A lot of people are posting them on both chat and the Q&A panel. They're specifically about how our TCOM's coded, but I think it also relates to how do I know what diagnosis code to use.
Yeah.
There's like so many questions coming to that, which I'm sure you're...
It's impossible for us to really answer all of those questions, because that's something I do spend my one-day workshops a huge amount of time on. It really depends a lot on your own facility, what instructions you're given about it, and because sometimes, as I said, you're instructed to just put down whatever the referring doctor tells you. But one thing you should not do is put down something that you know to be fraudulent. Whoever files the claim, meaning the facility that files the claim, is responsible if that claim is inaccurate or fraudulent. So you can't say, well, Dr. So-and-so told me this person had a stroke, and I knew that they didn't, because I asked them, and they said, oh, he sent me because I've had these headaches. You put down something you know that's fraudulent and just say, well, I'm told I have to put it down. Somebody in that facility is responsible. It may not be you as a technologist, but somebody is responsible. So what specifically I can't say on this webinar because there's so many different situations for everybody. The important thing is that you've got to understand that the Claims Act says whoever causes a false claim to be completed or to be filed, and it doesn't even matter if you get paid for it, just the file of it is fraud. So what you don't want to do is knowingly or continually put down stuff that you know is wrong. And people ask me this all the time, and there are ways to address this. A lot of times the source of that is greed, but a lot of times the source of putting down the wrong thing is just ignorance. I recommend that people start out by giving, if they have a problem with their employer, show the LCD to their employer. A lot of times also they can just, you know, sometimes I have people say to me, I've been telling my boss or my employer or my supervisor this thing that you've said today. They just wouldn't listen. Sometimes having something in your hands, an LCD or something that they need will make it will have a little more impact. But I think it's a big problem.
I posted the LCD information resource website because we had lots of questions asking for that again.
Yes.
And I just also wanted to let everybody know that the handout, the PDF file of your slides, is available currently on the Join the Meeting page. There's underneath the language on the left side, it allows you to download the PDF file. Or if you cannot get it and obtain it in that way, please send an email to webinars@intersocietal.org, and Natalie or myself will send you the handout in a format. So just to let everybody know, this will be posted, the recording from this presentation will be posted to the AC Vascular website only within 48 hours from today. And let me turn it to the next slide. There are so many questions, Rita, and
I'm seeing some of them.
Let me put another frequently asked question to you, and I'll put up the last screen, and I'm going to talk to the folks out there after you answer this question. They're doing some things not incorrectly or not correctly, and they've talked to the doctors and administrators about this, but nothing changes. What else can they do?
Well, like I said, some of it depends on what the problem that they're having is, but one of the things they can do is show them maybe the LCD if they think it's a compliance issue. Because, as I said, a lot of times it's really just a lack of knowledge about it. People really just don't understand that there are all of these requirements. And so that's where I would always start. And sometimes it's, you know, that's a lot of times when people come in, it's because they can't get anybody to pay attention to them until they have someone else come in and say, you know, this is wrong, you have to do it right, or this is this. The other thing is that, you know, if it impacts their reimbursement, they really need to be following their denials, because a lot of people are doing stuff wrong and they presume that they're getting paid for it. Like they may say, well, we have always charged that IMT as a 93882, as a limited duplex study, and we paid for it. But what I find is they don't know if they get paid for it or not, really. They're not getting paid for it when it comes down to it. So a lot of times people respond better to finding out that not only are they in a compliance risk situation, but that things may be affecting their reimbursement. Sometimes it's a matter of what the problem is, what is it affecting? Is it affecting reimbursement? Is it putting you at a compliance risk? And sometimes people react to different things. People are always willing to take a risk sometimes for compliance. That's why people, you know, steal, drive drunk, whatever. But sometimes if it affects their money, they make a bigger difference, and that's just human nature. So there are different ways you can approach it. I see one quick question I'll just answer. Is dyspnea an accurate diagnosis for LE venous? I can see that on my chat screen, and I'm going to answer that because this illustrative of a point that I want to make. In cases, in most LCDs, dyspnea is not listed. It's listed, but some of them list shortness of breath instead. So that's why you have to read your LCD. Some of those lines would be appropriate for doing a LE venous, but it may not be dyspnea. It may be shortness of breath.
Okay. Hi, Rita, sorry, I'm back. I put the slide with your email address and our webinar's email address for AC on the screen for those of you that want more information about, we mentioned doing follow-up presentations and being able to answer questions. So I put that up there on the screen, and folks can get them out from us at Webinars Societal. Thank you so much for attending, and thank you so much, Rita, for giving